Hi, I'm George Martin. I'm reporting to you from RWCS 2017. I was asked to do a lecture on skin biopsies and interpreting skin lesions and skin biopsies. I want to give you some of the caveats of my hour-and-a-half workshop. Number one, rheumatologists need to align themselves with a very good dermatopathologist. And to be a dermatopathologist, you have to be either a dermatologist or pathologist who goes through a dermatopathology fellowship and is skilled in dermatopathology. It's very important because of the in-depth knowledge that dermatopathologists have about skin biopsies, and as one who practices dermatopathology on a daily basis, I oftentimes find myself overturning the diagnosis of general pathologists who are good at pathology. But again, your dermatopathologist is the person you want reading and interpreting your biopsy slides taken from the skin. And if there's ever a doubt about a skin biopsy, feel free to send the report and accompanying slide to a dermatopathologist for a second opinion. As far as diseases such as lupus and dermatomyositis and scleroderma, a couple caveats I provided for the group here was, number one, when you're doing a biopsy of acute cutaneous lupus or cutaneous dermatomyositis, it's impossible to distinguish either on H&E, that's regular histology, or immunofluorescence between the two diseases. And so, again, H&E or immunofluorescence, it is impossible to distinguish between the two. You really have to rely on your clinical findings. Your biopsy will be consistent with either one or the other, but you've got to look for other telltale signs to help differentiate the two clinically. Discoid lupus, on the other hand, can be easily diagnosed by a qualified dermatopathologist on standard H&E biopsy. Immunofluorescence studies are actually non-contributory, may be confusing. So discoid lupus, you can make that diagnosis on biopsy. So regarding the biopsy, if you decide to submit a biopsy, a punch biopsy of a lesion, really be sure to include as much information as possible, and particularly go in depth about the patient's age, their ethnicity, the history of the disease, how many lesions were present, their distribution, what they look like, what your differential diagnosis is. And again, you want to provide as much information as you can to the dermatopathologist, because failure to do so, it goes back to the old term in data programming, and that is garbage in, garbage out. So your report will be as good as what you put into it. There's also, you really want to take a look at the report in depth when you get it back. Look for areas where there are comments. Those comments are vitally important. They help you and work with your dermatopathologist. And if there's any confusion, simply pick up the phone, call your dermatopathologist. On the subject of scleroderma, a biopsy from Morphea scleroderma and progressive systemic sclerosis look identical. The scarring process microscopically looks identical, so we oftentimes will have patients come in the office with a heightened state of anxiety with a biopsy of scleroderma when they simply have Morphea. So again, remember that the biopsy of both Morphea and scleroderma are identical, and so just let your patients know that if they have Morphea, it's a localized disease, and then you deal with the therapeutic algorithm. Be sure when you're doing your biopsies to not crush the specimen if you take a punch biopsy out, and that leads to artifact and potentially poor reading of the biopsy interpretation. And again, the dermatopathologist is your go-to person. A final reminder, make good friends with your dermatopathologist. Feel free to pick up the phone and give them a call, even if you have to send a report and biopsy slide from another pathologist or dermatopathologist. You really want the final clinical diagnosis substantiated with the report from a qualified dermatopathologist. So George Martin signing off from RWCS 2017. Hope to see you in 2018.